So hello everyone and welcome to case 30 of this case discussion series, and today we'll be discussing a very interesting case. So here we have a 80-year-old female who came with unilateral ballistic movement since the past 1 week now, and this is the MRI brain done for this patient. These are the T1 weighted images, axial section, generalized brain evolutional changes are seen because of the age. Here we can see that there is T1 hyperintensity seen in the left basal ganglia, the lentiform nucleus. These are the flare images where again we can see this hyperintensity in the left basal ganglia with some chronic ischemic changes in bilateral centrum semi-ovale. These are the DWI images. We don't see any restriction on the left basal ganglia. These are the GRE images. There is no blooming, ruling out hemorrhage as a possibility. This is a report I had given that non-contrast MRI demonstrated a T1 hyperintensity in the left lentiform nucleus, that is the basal ganglia, with mild hyperintense signal on T2 and flare as well. There was no obvious blooming which was seen on GRE images, and no abnormal restriction was seen on DWI images, and no mass effect as such was seen, which was suggestive of diabetic steatopathy. So what exactly is diabetic steatopathy? Diabetic steatopathy, also called non-ketotic hyperglycemic hemichoria, is a rare neurological complication of non-ketotic hyperglycemia. So when the RBS was checked for this female, it was about 250. So it was very high, and she was unaware of this condition, and hence was not on any medication. So along with a non-ketotic hyperosmolar coma and non-ketotic hyperglycemic seizures, it is a cause of hemichoria hemivalismus syndrome. Non-ketotic hyperglycemic hemichoria is most frequently reported in elderly patients, as in this case, and who have type 2 diabetes, and although because of the publication bias, but it is more reported in female patient. She was also a female patient. DDs for a T1 basal ganglia hyperintensity include hepatic failure, chronic encephalopathy, toxins such as carbon monoxide, uh, methemoglobin in intracranial hemorrhages, and also in Japanese encephalitis, but usually is bilateral basal ganglia involvement. Unilateral basal ganglia involvement is typically seen in diabetic steatopathy.